I'm Tamara Thomas, editor-in-chief of UrbanHealthToday.com, part of the DocWire family of medical news sites, and I want to thank you for tuning in to Urban Health Weekly. Our goal each week is to keep you informed of the latest in health and medical news right from today's headlines. It's time to empower yourself with open conversations about your medical care with news that matters to you. So are you ready? Let's get started. This is Urban Health Today, and I'm speaking with Quintin Maidment, Vice President of the Bliss Group and one of the leaders of the clinical trial recruitment business. He's here to talk about the clinical trial enrollment process. Thanks for being here with me today.
Oh, thank you for having me.
It's really good to have you here, and let's jump into it. Can you describe your primary responsibility as a marketing company in facilitating clinical trial enrollment?
Yeah, so at CTRX Pathways, so we work with pharmaceutical companies, academic institutions, health tech companies to help them recruit patients for clinical trials. We do this essentially through the creation of a lead generation engine that basically sends leads to clinical researchers, and these leads likely match the inclusion and exclusion criteria of that specific clinical study that we're working on. This is done through sort of a combination of data and analytics to sort of identify where potential enrollees are, both digitally and physically, paid media, advertising, earned media, like interviews with local publications, grassroots outreach. Sometimes that's like a partnership with a community-based organization. Sometimes that's actually physically pounding the pavement in areas with high rates of a specific disease. And then we sort of develop a website and a call center to sort of funnel through people through to the trial site.
Now, what is CTRX?
This stands for clinical trial recruitment, and the RX would be like a prescription, like an RX. It was just the name we gave the business line. Yeah. And then we do some ancillary services too. So we also provide on some clinical trials support around patient retention, certainly for longer trials that might maybe take a couple years. People drop off, they leave the trial, and you can leave a trial if you sign up at any time, but that's not great from a data collection standpoint. So we help clinical researchers retain patients, oftentimes through sort of like patient-based communication. We can help with designing protocols to make them easier to recruit so more people match the inclusion and exclusion criteria. And then most importantly, we really can help with selecting investigators and sites. Oftentimes, clinical trials don't necessarily take a sort of deliberative or data-driven approach in terms of how they pick investigators and sites, and there's that can have impact on trial success.
What strategies do you use to raise clinical trial awareness among potential participants?
Yeah, so it all starts really with understanding our sort of target universe and understanding the patients that we're looking to recruit. So we have built a sort of math model that underpins the advertising and outreach work that sort of combines a bunch of data sources. So anything from sort of, CMS and Medicaid data related to services and prescriptions written, demographic information, if there's correlations between the disease state and say, age or other demographic information. And then so we use that to sort of inform our target universe. And then from there, in terms of reaching participants, it can be earned media, so like a radio interview on like a local news station near a trial site, Facebook ads, search for people who may be looking for, typing into Google, symptoms of a specific disease or treatments for that disease. Talking to local newspaper reporters, talking to community-based organizations, which could be a church, it could be a fire department, a mosque. Really, really varies by the trial. And then oftentimes a lot of, for some diseases, if there's a patient advocacy organization, we often do partnerships with that advocacy organization as well. It's all really focused on fundamentally what drives patient throughput and getting patients who qualify for the trial to researchers. And so the exact formula really varies by the disease state, as some diseases are require more advertising. Some can do sort of more community partnerships or others are very focused on sort of disease awareness. It really varies by the type of trial that we're trying to recruit for.
Is this effort driven by the client? Do they give you a set of requirements and say, okay, we want these kinds of participants and we don't want them to have X diseases, et cetera?
Yeah, so oftentimes people hire us because a trial is not going as well as they want. So the number one reason that a clinical trial fails in the United States today is because you don't find enough patients to test the drug on. That is the reason that most trials fail. It's not a financial issue. It's just we just don't find enough patients to be able to accurately assess safety and efficacy of a drug or a medical product or diagnostic technology. So generally, by the time we get involved, there is the sites are all set where geographically where they need people, inclusion and exclusion criteria. So we need people who have diabetes, but they don't have a history of heart attacks, or sort of whatever the specific inclusion exclusion criteria is. That is all set by the researchers and is designed to sort of support the endpoints that they're looking for. If we are involved a bit earlier in the process, we can make suggestions on the inclusion exclusion criteria based on our estimations of how many people will meet those. But fundamentally, those at the end of the day are set by the researchers, and especially as medicine is becoming more personalized and treatments are becoming more tailored, you're starting to see very, very narrow inclusion exclusion criteria, especially in the cancer space. In oncology, inclusion exclusion criteria can be very, very specific.
There's a big push for diverse trial participation. How do you tailor your communication to reach diverse populations?
Sure. So if I can actually just step back a second on that question, if all humans are genetically the same, why does diversity even matter in trials, right? Why do we need to recruit a diverse patient population if every single human is genetically the same? And there's a couple reasons for that. Sometimes there can be slight differences in metabolization rates. We all have a friend who can, no matter how many slices of cake they eat, they're effortlessly thin. And there are some, not necessarily with race, but for sort of region of the world where people come from, there are some differences in how quickly people metabolize things, which has impact on safety and impact on dosage. And there are obviously diseases that disproportionately impact specific races or genders or ethnicities. Sickle cell is an obvious example. So is lupus. And if we're not able to recruit patient populations that are reflective of the disease state, we're not going to be able to kick some of these diseases to the dustbin of history. And also too, trial participation does come with benefits. Oftentimes we're working in disease states where there's no existing treatment on the market, and in those situations a trial could be the only way to get early access to these treatments. And that really needs to be sort of available and accessible to others. In terms of how we work to promote clinical trial participation among underrepresented groups, it does vary. A lot of the issue comes down to trial selection. Oftentimes, academic institutions will work with other academic institutions. Now that makes a lot of sense, right? Universities have resources. Universities have expertise, they have knowledge, they have experience. It makes a lot of sense to partner with an academic institution. The problem is, however, if you look at where academic institutions are generally located, they're often in kind of wealthier parts of town. They're in maybe whiter parts of town. And they can be kind of hard. They're not well served by public transport. They can be kind of hard to get to for people, for sort of historically underrepresented groups. So a big part of the thing that we like to work on is are we advising our researchers to partner maybe with a federally qualified healthcare center, which sort of serves lower income patients, community facilities like urgent care clinics. There are other sort of embedded healthcare facilities which can often do a better job, or also be able to reach a more diverse audience, even if they don't have the same low level expertise as an academic institution does. Other strategies that we do really making sure that the imagery that we're putting out in advertising is representative. If you're doing not necessarily just by race or ethnicity, so people can sort of see themselves in the trial, but also too, does the age or lifestyle of the photo actually reflect our patient population? Recently we've done work on osteoarthritis trials that it skews older. You don't want to put a fit young person in the banner ad. You want maybe an older African American or Asian American, or you need an older person to sort of really match the trial demographics. People need to see themselves in the ads to realize that it's for them. There's some stuff you can do with data analytics. So the CDC publishes disease incidence rates by zip code and by census tract. So you can overlay that with demographic information, and we can say, oh, in this specific neighborhood, we see a large amount of the disease that we're looking for, and also a large amount of African American or Hispanic residents. That could be a good neighborhood to focus our Facebook ads in, bus ads, that kind of stuff. A lot of stuff around community outreach. So going into these neighborhoods that we've identified as high rates of disease, high rates of non-white residents, are we partnering? Do we have information outside of, say, supermarkets, churches, mosques, temples? Are we partnering with one thing we did during the COVID trial, actually? We partnered with the Public Transport Authority in Miami-Dade County in Florida. That reaches a low-income and diverse audience and makes our trial accessible to everyone. And then another thing, too, is really looking at the investigators and trying to identify, using data analytics, who is quoted commonly in ethnic affinity newspapers, who is commonly on the news talking about this disease state, who has credibility within all types of communities near trial sites that we're going, and can we make a strategic selection with investigators to make sure that we are picking people who are trusted, respected, credible, known to all populations near the trial site, but particularly for underrepresented groups. And then there's also too simply putting your money where your mouth is. So are we making the kind of advertising investments that we need to make with African American newspapers? Are we targeting our advertising dollars to reach everyone who is eligible and should participate in the trial? And are we actually putting in the effort, both financially and in labor hours, to reaching diverse communities and sort of making the trial accessible to everyone?
Okay, so I have a disease.
Mm-hmm.
There's no known medication that I have access to, but there may be a clinical trial. Walk us through the initial steps a patient needs to enroll in a clinical trial. Where would I start?
So the federal government, in theory, keeps a database at clinicaltrials.gov. I say in theory. Everything is there. It's not always the most accurate of databases. Oftentimes, if it was easy for you to find, I wouldn't have a business. In short, we wouldn't have this as a business. This wouldn't exist. Oftentimes, academic institutions, they will post trials on their website, but it's very sort of scattershot, and it's very difficult for people to discover a clinical trial for themselves. There are some exceptions to that. Rare disease, if there's a disease where there's 300 patients in the US, there's probably a very well organized disease awareness society that knows where those 300 people are and knows the 2 or 3 trials that are going on and can connect people. Most diseases, that isn't true. When we worked on the COVID trial, and you got a positive, we were looking for people who had just gotten a positive COVID test. But if you got a COVID test, you're not thinking, oh, I should go join a trial to find a treatment for this disease. It wasn't even registering in people's minds. Right. Oftentimes, how people discover the trials is because we serve a Facebook ad or a Google ad or a search ad to them, and we do that based off of you're looking at content related to that specific disease. You might live in an area with a high prevalence of it. You're searching, like for, COVID's in my mind, like, oh, I can't smell my candle. Boom, we can serve an ad to you on that because it's a symptom of the disease. And then oftentimes from there, patients can go on a kind of long journey. Oftentimes people will discover our ad, then they'll go look at the clinical trials websites, they'll search around to see if there's news articles, and then they'll sort of come back in to our trial website, and they'll sign up to have a conversation with with an investigator.
That sounds though like you have to have a certain amount of sophistication as a patient to even begin that journey. What about someone who is low income or marginalized and doesn't have, or let's say, they're working, 12
Sure.
hours a day and they just don't have the means or the time for that kind of research?
Yeah. One thing that, I mean, if there is sometimes primary care physicians or in some institutions are kind of good at funneling people from the clinical side of the entity to the research side of the entity and identifying patients who might be eligible during like a traditional medical sort of checkup. But we all know that lots of people don't have a primary care physician. And,
Exactly.
For a lot of people, especially lower income people, and especially in the American healthcare system, access to care can be an issue. Oftentimes during the COVID trial, it's a little easier because we were able to, go to COVID testing facilities and stand outside of them with signs and information on the trial for people who were in a very distant and COVID safe way, for people who were, potentially, able to enroll. And we in that example of we hired people who had multiple jobs who caught COVID during their shift at a fast food establishment. But it's that we also do generally, it varies by trial, but we often try to do more to relieve the financial burdens of participation. So oftentimes people are most trials compensate people for their time and effort in the trial. It's a reimbursement. How much money that is varies quite drastically. Sometimes it's a couple $100. Sometimes it could be a few thousand. Oftentimes we encourage researchers to budget for paid transportation to bring people to trial sites who might not live near them. And then a lot of people really discover our trial through advertising, I would say mostly. Yeah.
Okay, so they've discovered the trial through advertising, and then
So they discover the trial through advertising. Sometimes people sign up right there and then. That's the only nudge they need. They see, oh, it's with the big university down the street from my house. I'll go sign up or in my town, I'll go sign up for the trial. Other people leave and they go Google around. They'll be, they'll search for it. Maybe they find a local news article where the principal investigator is being interviewed by, the local TV affiliate. They'll listen to that interview. They'll sort of do their own research and go, okay, this is a legitimate thing. This isn't a scam. And they'll go through and sign up. We have noticed actually when people do sign up in our initial contact us form, we generally don't require a last name. We've noticed that people are a little hesitant to give up their full identity, but will happily give their first name and a phone number to learn a bit more. And so oftentimes we sort of will just push people through the funnel, and then we will do a bit of initial pre-screening, just to check to make sure that you meet the inclusion exclusion criteria, because it's not good for the patient and it's not good for the researcher for us to send you to a site. Especially if you have to take time out of your day for a physical workup, to find out that you are not eligible to participate. So we try to only put people forward who are eligible to participate.
okay, so that leads me to an important question, because you talked about the inclusion exclusion.
Mm-hmm.
and then the physical workup, which means that you've made it through the inclusion exclusion part of the screening, right? Okay, so now you got to the physical workup, and have you found, or better question, what have you found, if you could give it as a percentage of how many people end up being excluded in the screening process? So let's say you have 100 people, how many of those people end up making it through the physical workup?
That varies, I think, drastically by disease. I would say by the time you've gotten to the physical workup, you will pretty much be, unless something is discovered in that, which will probably be, is probably a comorbidity issue that you weren't aware about, which is, probably a good thing to have discovered. It's pretty unlikely at that point to have failed. So, you'll get a basic screening on our website, or our call center, which is not complicated. It's just generally 3 or 4 questions. Do you meet like the big ticket requirements for the trial? Are you within a certain age band generally? Do you have a diagnosis of this disease? Are you taking a specific medicine that's excluded? From there, those leads get sent to basically the site, the clinical researchers, and at that point they will often do a more detailed phone screen to make sure you tick every single box on the inclusion exclusion criteria. There's generally like 15 boxes that have to be ticked, and we pre-screen for about 4, and then from there people will be brought in for a workup. People in some conditions like neurology, so like Alzheimer's or cognitive decline, failure rates can be a bit higher. But some of that's also an issue with self-selection. So people who raise their hands and saying, "Hey, I've realized my memory isn't as good as it was 5 years ago," are often people who have better memory, or hypochondriacs. So that could be a challenge within the neurology space. And those kind of diagnoses are a bit. There's objective criteria to cognitive decline, but it's fundamentally there's a value, there's like a judgment call that a medical professional has to make. And so failure rates in those cases can be a bit higher. In our COVID study, for example, where it was, are you over 18? And do you have a COVID test in the last 5 days? Hardly anyone failed at the screening point, because those were basically the only 2 criteria. When it gets more complex, when there's more exclusions, the failure rates go up.
So let's talk about the comorbidity for just a second. Because that seems to be an area of high exclusion for people of color, right? Obesity, diabetes. I'm curious if you've seen any movement towards, okay, we'll change our criteria to include controlled disease. Like if they're, the medication doesn't necessarily, contraindicate with the medication that they're testing. Have you seen that shift, or is it still a kind of a sticking point?
That's a big. I'm working on this cognitive impairment study, where diabetes is an exclusion criteria, and it's because I'm looking at that one has been very difficult to recruit in, and because the drug under test is a drug used for diabetes, we can't change the inclusion exclusion criteria to allow it in a controlled situation. We've certainly seen a greater level of mindfulness from researchers in the earlier stages, thinking about the impact that specific wordings of inclusion exclusion criteria are going to have on the ability to recruit. And we've certainly seen a willingness to put in requests to change inclusion exclusion criteria based off of the sort of the challenges of recruiting patients. So I think there have been some efforts to that. It does, unfortunately, there are some situations where you just can't change them, which is unfortunate, but unfortunately the situation that it is.
important is the principal investigator in enrolling clinical trial participants? What's their role?
Huge. The role of the site and the role of the investigator cannot be overstated. And we've consistently seen that it is maybe you'll have 10 sites, but 2 of them, 3 of them will get the majority of the patients. And that often comes down to the principal investigator himself is very personable, or is really committed to the trial. There's lots of correlations that we have found between the time to respond to a lead. So sites that respond to a lead within 30 minutes recruit way more patients than sites that wait a day or 2. And picking good investigators is key to trial success. Is certainly key to trial success, yeah.
How is patient eligibility determined for clinical? What percentage of your screen participants get accepted?
We aim for north of 50%. It really varies by trial and capacity. For some trials, it needs to be basically everyone needs to get in. It's a balance, because every time we add an extra question to our pre-screening, a certain percentage of people drop off. It's the same as buying a good online. If you buy a good online, there's a reason Amazon lets you do one-click purchase and it shows up in your house in 2 days. You're not going to think as much about it. You got to flip through a bunch of forms. You're like, ugh, I'm busy. I got better things to do with my life. Particularly if you're using a not great, like, cheap Android phone that doesn't have great web capabilities. You kind of just get aggravated and you just sort of leave. So every time we add a question, we lose people, and we lose people who might actually be eligible for the trial. So say if you have 4 questions and 10 people get through, and 7 of them end up being eligible. But say you add 5 questions and 9 people get through, but you might only get 5 patients. So it's a balancing act to make sure that you have the patient throughput meeting the site capacity. Oftentimes how precise we need to be is really dependent on how much capacity the site itself has to screen patients more in depth. So some sites and some, investigators and trials are like, just send me, everyone you can get your hands on if you think there's a chance that they'll be eligible. We'll settle it and screen it. Other sites, it could be like, well, I've got 10 trials. I've got 10 trials going on right now. I need very accurate people because I just don't have the time to pre-screen. A clinical coordinator might quit, and now suddenly the capacity to pre-screen at a site is gone. So we need to tighten up there. Often it really comes down to the site's needs. And I think key to our success as a marketing firm has been really embedding ourselves with the sites, making friends, constantly getting feedback from sites. Patients are failing. There's often patterns that sites can tell you. Patients are failing because they're on this specific medication that is contraindicated. Okay, we need to adjust the screening for that. So it's really just like embedding ourselves with the sites and making sure that the people, on the ground and on the front lines are actually giving us the feedback that we need. And oftentimes we also try to have those conversations with the sites without necessarily the central trial leadership being on those calls, because we can people can be a bit honest, are more willing to be honest with us when they don't have to sort of worry about how it might reflect on them or how they think it's going to get the principal investigators to think on us. And so it allows for a level of more sort of open chord communication. And so it's about embedding with the sites and really making sure that we're attuned to local realities and local site needs.
To me, 50% doesn't sound, is that a good number, 50%?
It really varies on the disease state, to be honest. I would say the majority of those it really varies on the disease state and for the trial condition. We've been doing a fair amount in neurology recently. So like cognitive decline, Alzheimer's, that kind of stuff, where failure rates are way higher because the diagnoses are a bit more subjective. Whereas if we were just looking for people who had like diabetes, and who are over the age of 50, like that is going to be way easier to find people for. And our failure rate for that should be 5%, 6%. It should be around there.
I'm curious what your relationship is with, I'm just wondering if relationships with primary care, you mentioned that briefly earlier, but how important that is in getting accurate information about potential participants.
Yeah, so for some like academic medical institutions that they have like a hospital associated with them, sometimes those systems are very good at speaking to each other. And so that there is an ability for a primary care physician to like sort of to know of a trial and to recommend it to their patient. Obviously patients have privacy rights, right? Nobody wants to go to the doctor and have their private disease information sort of being shared around. So there's lots of restrictions from a privacy perspective, as there absolutely should be. There is some level of potential advertising capability within electronic like health records. Like sometimes we'll work in situations where it is allowable for us to send out a push through the electronic health records to patients who may be eligible, but there has to be like a lot of patients who are eligible, so there isn't like a data privacy issue. We can certainly identify physicians who might be heavily treating a specific disease based off of reimbursements for prescriptions that they wrote or medical services that they wrote that they billed to Medicare or Medicaid. If you write a certain number of, and the number is not available on top of my head. If you write a certain number of prescriptions for a specific drug a year and you bill that to Medicare, that is public information because it's tax dollars. Now we don't know who that prescription was written to, and there's a threshold, so we can't like re-identify it. But we can tell, this primary care physician writes tons of prescriptions for diabetes drugs, so they must see a lot of diabetes, particularly in states that have more loose, sorry, I say they allow for broader scope of practice of physician assistants and nurse practitioners. That kind of data can be very useful for identifying people who might be registered or consider themselves to be primary care physicians, but for whatever reason, they have, developed a patient base that has a specific disease state and they're known for a specific expertise. Oftentimes in New York, for example, allows for nurse practitioners to write scripts without a doctor's oversight and do a level of independent medical care that other states don't allow. And so oftentimes in this data analysis, we'll get the specialist for that condition, but we're also getting a lot of lists of, primary care physicians and nurse practitioners who are writing a lot of drug scripts for drugs that can be used to treat a specific disease. That can be useful for reaching medical professionals. We do, depending on the budget and depending on the disease, we will do a level of physician marketing. So that could be mail pieces, Sermo advertising, LinkedIn, sometimes trying to get in front of professional associations and getting into professional association newsletters, doing partnerships with, or like really presentations to medical professionals when we can has been incredibly effective. And then oftentimes we found in some trials that primary care physicians can not necessarily oppose clinical trial participation, but they can sometimes be a bit hesitant about it, and they will suggest that their patients not really do that, or they'll say that this drug is useless or whatever. And so sometimes we have to do advertising campaigns or education campaigns to local physicians in the area just about the existence of the trial, so that they've learned a bit about it before their patient has asked them about it.
I read recently that somewhere in the neighborhood of over 90% of doctors have no idea how to even navigate the clinical trial process, let alone get their patients involved in the clinical trial process. So I'm glad that you guys are advertising in that.
Mm.
Okay, so once enrolled, so now the patient is enrolled. They've passed the physical workup, you know, they've all the exclusion criteria that now they're enrolled. What kind of support can participants expect?
Sure. So often actually one of the big benefits of clinical trial participation is that you get a level of like concierge medicine or access to the clinical researchers. And so you have a level of like oftentimes ability to call, the clinical researcher up to talk about your symptoms if you're having a flare up. You can often get to sort of jump the line in some ways. You get oftentimes a lot of clinical trials will come with, and one of the reasons why people do this is these full body workups. They're not clinical diagnoses per se, but you'll get a copy of your MRI scan, you'll get a copy of your full body scans that are done, any blood work done. It's not a clinical diagnosis, but you'll certainly be able to get a level of scans that would be tens of thousands of dollars if you try to pay for it purely in cash. You get a lot of access. How much patient burden varies by the trial. So for some trials we work on, you have 3 visits. Other trials you might have to show up every other week. It really varies, but oftentimes researchers make themselves very available to their patients. And so you get a level of like concierge attention that you just you wouldn't get if you just did through the regular primary care system.
So as far as patient burden, is there financial assistance for low income participants or their support person? Let's say the drug has, they require care at home, or they're sick from the effects of the drug. And does that person, the person who's caring for them, do they get, because oftentimes it's not just the person who has to take time off of work, right? It's the person who is caring for them who also has to take time off. There's also the consideration of the childcare. So when we're talking about this concierge medicine like care, does that include that as well? Financial?
Yes.
For that?
So there are some trials where the medical care isn't free. That's rare. That's extremely rare. So in most trials, 90% plus, all the medical care is free. And then you get a reimbursement for sort of like time and travel. That is generally paid out to the individual participant rather than their like caregiver. I haven't seen a specific payment for caregivers. The financial reimbursements really vary by trial. They can sometimes be quite generous. And they can be a good chunk of money. During the COVID trial, actually, it was $445 for participation. And that, COVID would have probably knocked you out of your day job for a week or two. And oftentimes, if you got sick, your wife or husband also got sick. And so you'd get $900 generally if both of you signed up for the trial, which is for basically 7 days worth of work. The transportation, obviously the caregiver can come with transportation. The caregiver can obviously go in the free cab ride and come with the patient to the trial. But reimbursements are generally always given to patients and their to patients, and oftentimes the caregivers who accompany them are in the informal caregiver category. So they might be like a child or a family member of some child or spouse or family member of some sort. There isn't I haven't seen a direct payment to a caregiver yet. But that's actually an interesting idea.
Is there a way that you can, and if you don't have this information, it's okay, but do you have an informal breakout of the demographics of your screened and accepted participants?
Yeah, so I do for our COVID trial, because that like fully wrapped and published and they published the demographic results. So I actually have those, and I pulled them in my document. Oh, here it is. Okay. So for the COVID trial, when we started, the trial was 87% white. By the time we ended, it was 66.41% non-Hispanic white, which is a little above US general demographics, which is about 59-60% non-Hispanic white. Black participants were 13.8%. Hispanic participants were a little under 15%, a little under 2% for American Indian, Native Hawaiian, Alaska Native, which roughly correlates to demographics. And then Asian participants were probably below targeted, about 4%.
So according to the NIH, 77% of clinical trial participants are generally white, 15% Hispanic, 14% Black, and about 3% Asian. In your experience, what have you observed regarding why there continues to be like an underrepresentation in clinical trials, especially for Asians and Hispanics, who represent what, 6% and 9%, 19% of the population, respectively?
Yeah, I think a lot of it really comes down to the site selection. So there's an issue with this accessibility and travel. And oftentimes these are at academic institutions, which makes sense, right? They have the expertise, they have the knowledge. But they're just you take the University of San Diego is a great example. You think, oh, San Diego, this is a heavily Hispanic area. But you look at exactly where the University of San Diego is. It's in La Jolla, with a beautiful view of the Pacific Ocean and $2 to $3 million mansions that surround it. It's a very affluent area. It's a very white area, and its public transport links to the rest of San Diego are not great, to say the least. And so you just don't have. It's just not in convenient locations, which is a big issue. Some of our trials, particularly more commercial ones, have partnered more with like an urgent, like a city MD that's in in New York, in Crown Heights, or in a heavily majority minority area, which just helps because it's physically easy to get to. It's one of the you don't want to travel an hour to go to a clinical trial. You want one that's in your community and in your neighborhood. And if these are just in heavily white areas, you're just not going to be able to recruit as effectively as you wanted to. I think from our experience, it was really required to have the good results that we had during the COVID trial. We got pretty close to US demographics. It was really doing like a fully integrated communication and marketing strategy. So we needed to target influential religious leaders, community validators, political leaders, medical workers who work in diverse communities. Put street teams on the grounds to go, basically pound pavement and talk to people about the trial and why they should participate, and bring it to people's attention, right? Because they just didn't know about it. And then that traditional, advertising and putting the dollars behind, reaching non-white communities, and really also to getting the researchers, media interviews with, publications that reach reach Spanish-speaking audiences, or reach Caribbean American or African American audiences. And oftentimes I think it's more challenging to do that. It can be easier just to recruit off your known patient pool, and putting in that kind of work is a burden to sites. They would love to do it, but every researcher has like 3 or 4 jobs already, and it's another thing for them to do. And they just want to get their trials filled as much as possible. I certainly think that the federal pressure and incentives that the National Institutes of Health and other groups are giving to promote clinical trial diversity and really set diversity targets tied to grants. So in the last couple of years, the NIH has been, when they give grant applications to academic institutions to do research, they have started to require specific demographic targets to be hit to unlock certain portions of the money. And obviously, that has helped greatly. Most of those have been really focused on recruiting African Americans and Hispanics. I haven't seen much federal pressure around recruiting Asian Americans. I certainly would expect that to change in the next couple of years. And I also think another challenge too, especially with Hispanic and other immigrant groups to the US, they oftentimes people, they speak English in their day-to-day for their job, but for things that are complicated, that might involve financial information or healthcare, they might prefer
literacy, in other words.
Yeah, exactly. They might prefer it in their primary language, because there's a level of, I speak French badly. I can read a French newspaper headline. I could not understand an informed consent in French. I would need that in English, because I need to understand the nuance behind it, and to really truly understand things and make things more comfortable. It's not like, they're non-English language speakers. It's just, it's just complicated, and it requires nuance and understanding, and there's slight subtleties of what exactly is being communicated. And so really putting, translating trial recruitment materials into multiple languages, doing the advertising in multiple languages, and showing that this trial is open to everyone, definitely I think helps a lot. We've done a fair amount of PR campaigns to non-English language media, which is big in the US. There's lots of newspapers that publish in various languages of immigrant groups throughout our country.
To your point about site selection, Mount Sinai, for example, they use a shuttle bus to get people to their location. But back to what you were saying about health literacy. So I would imagine that this is probably where a support person comes in, right? Because maybe that person speaks more English than they do and may be able to help them navigate. I'm just.
Yeah. So oftentimes, most hospitals have it's quite rare that they have a translation service within them, so you can call up and you can get someone to translate. It's oftentimes the translations of materials is really it's just for the helping people feel more comfortable, because they fully understand the document and the nuances.
For example, with Spanish language, so a Mexican Spanish speaker, they're going to use different idioms than Paraguayan, or different from native Spanish. So there might be instances where it doesn't fully translate. They don't often use the same words for the same things. So I don't know that would be sufficient.
Spanish is interesting. So if we have a large amount of budget for advertising campaigns in Spanish language, we will actually cut them in multiple versions. So we'll cut a version for the Northeast that uses, Dominican and Puerto Rican terms. But if we're going into the Southwest, we're going into California, it'll be close to Mexican Spanish. It is not. Yeah, it is. That's a very good point. It is not one language in the US or one language in Latin America. It varies quite drastically on nation of origin. Oftentimes with Spanish language informed consents, we'll advise creating two versions of them. So there'll be one that'll be more for South American immigrants, and one that'll be more for people from Central America. That is, ideally you could do one from every country of origin, because there are idiomatic differences. But when we can, we do try to do that. And then we encourage, if there's translation resources on hospital sites, often as well as yeah, people definitely bring. I mean, my parents are immigrants, and they have me read over complicated things that don't understand the American healthcare system, and they speak English fluently. But and so oftentimes people will rely on their kids to sort of help navigate the system. When there are having being able to understand that sort of, I think, cultural nuances and linguistic nuances across Spanish really helps to make sure you have actually like fluent Spanish speakers on staff for us. And that's certainly, that's a even more complex if we were trying to do a campaign in Chinese in New York,
Right,
right?
because you've got Mandarin, you've got Cantonese, you've got the other dialects.
We're trying to recruit patients in New York City has 4 Chinatowns, right? We've got Chinatown in Manhattan, that's a Cantonese speaking Chinatown. We've got Chinatown and Sunset Park in Brooklyn, that speaks Fusionese, which is generally where sort of lower income Chinese American immigrants come from. We have Flushing, that's Taiwanese and Mandarin, and there's some subtleties between those. And then you've got a Chinatown in Elmhurst, Queens, which is very Vietnamese. And if we brought in 4 Chinese New Yorkers, they would argue for hours over which dialects we should use. So it's even more complicated in Chinese for sure. And it's Spanish, Chinese. It's also too, it's like, are we actually confirming what we think is true with people who come from these communities? I think is the important, and it's like a lot of these things. It comes down to really listening to people and understanding what they need and actually, is this actually resonating?
Then you have French and Creole. That's
Mm-hmm.
so it goes on. So in your non-clinical estimation, if there is, where is there a disconnect between potential participants in clinical trials? If you've seen that.
One, I think most people are completely ignorant of clinical trials. And I mean ignorant in the most neutral statement of them. They're aware of them in the way I'm aware of sports. We know it's going on, but we have no clue what's actually happening. And then I think other side of it is often people see this as like human guinea pig. That they're going to be testing something scary or unknown. And I think that's a part of it where oftentimes it's like, oh, this is a drug that's approved in Europe, but we need to get data to get it approved in the United States. This is a drug used for diabetes. Now we want to see if it can be used for, to help prevent cognitive decline. Oftentimes there's concern of this is going to be a dangerous kind of thing, where it's oftentimes actually by the time you're testing it on humans, there's been, especially at a wide scale trial, there's been all these smaller trials to test for safety, to make sure things are as safe as they can be. There are obviously risks of experimental medicine. I think people have a lot of just instinctive fear of clinical trials, and see it as this like big scary thing, or that they're only for you have a terminal disease, and so that's why you join a clinical trial, because it's a lost ditch kind of hope and prayer, where actually this is this could be a foot fungus medication, it could be a medication being repurposed, and therefore a lot broader disease states than people I think they are.
So in your estimation, the resistance seems to be on the patient side then, not any unconscious bias on the parts of the institutions. I'm not putting words in your mouth, I'm just asking.
Yeah.
Because if people are ignorant to clinical trials, then I don't really see how they can be fearful of something they
don't. I think by ignorance they know that they exist, and like I mentioned this to people like I'm talking to I'm trying to reshop my car insurance round, and I mentioned that I do this kind of work, and they're like, oh, you're looking for human guinea pigs. Like that kind of reaction is like the instinctive thing that I get from the random customer service phone calls, which is my scientific way of looking at this. I just think that there is that sort of like biases within it. I think as a communicator, right, as a marketer, I always say that if somebody doesn't understand something, it's my fault for not explaining it properly. And so I think that there is a level of, certainly a level of bias. I think a lot of it comes down to like there hasn't been a concrete enough effort to explain the trial and its benefits at scale. And every trial is very unique in terms of like what it needs and who it needs to reach. Um, the I mean, certainly like there hasn't been, the ad council doesn't run ads talking about, why clinical trials are important, right? There isn't really that big push from the federal government to sort of explain research and its importance. I would say that there can sometimes be a level of like, it requires more advertising dollars to recruit people who are distrustful inherently, because you have to educate in a more complicated way. You have to have more touches. You have to be more patient, and that has dollar costs. In terms of advertising costs, time is money in terms of researchers' times, and oftentimes because it was expensive in the past or it will be expensive, there's just hesitancy to do it, and there is like a bias against doing that and advertising more aggressively in lower income areas. But I mean, I think that I think ultimately at the end of the day, as researchers and as people who recruit patients, we have to like evangelize and go out about the importance of clinical trial recruitment. And I think, I mean, it would be something I would love to see maybe an industry trade association or the ad council really get on and get out and explain why clinical research actually matters and how people's direct participation in clinical trials leads to new drugs on the market.
What would you say are the biggest lessons you've learned, or the biggest lesson? What is the biggest lesson you've learned in your work connecting patients with clinical trials?
So many good ones. I think, I mean, how disjointed everything has been really shocking. You mentioned earlier 90% of doctors have no clue. The fact that there isn't a good system to put people in clinical trials has been kind of shocking and eye-opening, and it makes you think about how many people are unnecessarily being impacted by disease because we're failing to connect people properly. That has been that. I think you see consistently within all the researchers that we work on a level of, absolute passion and commitment to finding cures and finding better treatment options and better treatment modalities for patients that often really, really, really comes across in people who have dedicated decades of their lives to studying a specific molecule or a specific disease state. And they have a level of like expertise and passion, which is really just like awe-inspiring to listen to. And I think what I think I've taken a lot of pleasure in is really when we present to academic institutions and researchers and be like, hey, this is the basics of marketing and how you can apply marketing strategies to your patient recruitment for trials we might not even be directly working on, right? We've just been hired to go give this presentation and talk to academic researchers. And every academic researcher we talk to is far, far smarter than I am. But they're not marketers. They're not marketers, and they're not salespeople, and helping them apply those lenses and the skill sets that we have when combined with their scientific expertise, really, I think has helped improve, trial outcomes and trial results. Yeah, I think it's certainly been an experience, and we've been doing it since 2020. And it's been very different than anything I've ever done previously in my life before.
So it sounds like it would be advantageous to the research community to have relationships with marketing, have marketing companies, at their side to help bridge the gap between, because there is that failure. And neither side seems to know how to get to the other side, and so marketing that bridge. That's interesting to learn. Thank you very much. Quintin Maidment of the Bliss Group. Thank you so much for your time and for shedding light on the clinical trial enrollment process and all its fits and starts.
No, thank you so much for having me. This has been great.
Thanks for listening to Urban Health Weekly today. I hope you'll join me and my friends next week so you can stay informed and inspired to take control of your health. See you next time.